So the HIN topic that we chose to focus on was sepsis. It is a core measure that has been a focus of ours for many years, since October of 2015 when it became a core measure, and it's something that we have done a lot of improvement work on over the years, but we most recently had a refocus simply because we report the data into our quality improvement committee every quarter, really more often than that. It's every month because they see the data on our dashboards, and sepsis is on our dashboards. And so in the beginning of the year 2019, at the first quarter, we had a new medical staff QI committee, so they were fresh eyes coming into the committee, and they saw our trend data for the last year and really wanted a deep dive focus. Why, where are our fails? Why are we failing? And with Kristi, the ER ICU director, myself and the quality improvement team, we, and with our just core measure data, we were able to deep dive and really look at where our failures were coming from. And not that we didn't have some failures kind of across the board and in different places, but we were really able to trend down the data and see that our failures were consistently related to IV antibiotic start times. So not that the orders weren't getting put in within 3 hours, but that the IV antibiotics were not being given within the 3 hours. And so as a team, we collaborated, used an HRET tool that came through a listserv, and were able to modify it. We didn't do too much changing with it, but created a tool that we made our own and implemented. And Kristi has really been key in education to the nursing staff and implementing the sepsis communication tool.
Well, and we found out that through the ER that the standard type of education did not work. They see very critical patients on a routine basis, but most of the patients that they see the results of their work fairly immediately. With sepsis patient, the concerns are the things that happen after they leave, the things that happen over 2 days, 3 days, 4 days, even 3 or 4 weeks, and the mortality and morbidity rates that are associated with that. So we had to find a way in educating them to make them understand that it was as important as a trauma, that it was as serious as a loss of limb or a gunshot wound or a CVA, a heart attack that came in. And once we had those conversations, you could kind of see it clicking with the nurses, making sure that they understood these patients, you may not see the end result in the department, but 2 weeks or 3 weeks later, we've changed their quality of life because we didn't perform these steps in a timely manner. On the physician side, I feel like we had a big hitch with the ER physicians in trying to get that 30 mils per kilogram of IV fluids, because there's a lot of concern if you have a CHF patient. They're worried about overload and what's going to happen afterwards. So then that required communication between the doctors that were taking over the care once they were discharged or admitted from the ER, and knowing that those doctors could handle those problems, so to go ahead and give those levels of fluids, and then the maintenance care would come later. And so it was just a matter of having confidence in the staff all across the board in order to get some of those problems resolved.
Something else that we've done consistently since the beginning of the sepsis core measure was communicating failures back to not only the providers, whether it be ER or the PCPs who take over during that 6-hour time frame, but then also to nursing. So what we did recently is started communicating the positive. So that's something that I just didn't do. I really focused on communicating the failures, and we got feedback from that, but I am finding that I get so much more feedback from the thank yous.
Absolutely.
And so what we have kind of started is a CRMC sepsis superhero. So every time I abstract a chart and I see that an ER nurse in particular gave the IV fluids within the time frame, gave the IV antibiotic within a time frame, then they're getting an email from me just saying thank you, and I tag in Kristi, I tag in Sarah, our CNO. So and they email me back. They never email me back with the negative, with the fails,
Right.
but they definitely email me back with the positives. So I feel like that's been very influential.
I do too.
Well, just one wrap-up question. How do you envision advancing this topic in the future?
I think we'll continue on the path that we're on. We are already implementing a few things. We started the circle with the initial education for sepsis, and then we brought on the sepsis communication tool, and then we have the hospital-wide high fives and the goals, and now Abby's doing the superhero where she's acknowledging that. And I think the closure on that is to give them feedback about their documentation too. So now we have a sepsis tool where we audit the charts and we're showing them specifically where the areas of improvement could be. And I think for nursing, that's something that they crave. Ultimately, we'll have them doing reviews of each other's charts, and I think that that's gonna kind of end up kind of making a full circle for us.